Hi, and welcome back to our interview series on breaking the silence of maternal mental health. Today, I'm pleased to welcome Dr. Catherine Monk, Diana Vagelos, Professor of Women's Mental Health and Chief Division of Women's Mental Health in Obstetrics and Gynecology. Her pioneering research and clinical contributions have involved, for example, exploring the link between the biology and psychological pathways of mental health and have resulted in leading many interventions to supporting mothers' well-being during and after pregnancy. So, Dr. Monk, hi, thank you so much for joining us today. We're really
Thank you.
pleased to have you here.
Thank you so much for having me.
Great. And if I could just start off by asking you to start, what first interested you regarding maternal mental health? What led you down that path?
Yeah, I think as is often the case for many of us, there are multiple influences over time. I certainly came of an age in the early 70s when there was sort of a second wave or third wave of feminism, and my mother uh, bought me a Junior Ms. t-shirt as Ms. Magazine was getting started, and I think that influenced me thinking about women's positions in society. Um, it's thinking about maternal mental well-being, so mental health in the pregnancy postpartum period is really an opportunity to think about biology and psychology and the bidirectional influences that contribute to risk for mental health conditions. And of course, those factors and processes are happening within the context of someone's life. And again, women's condition in societies, there can be experiences of added stressors. So it really allows us to and invites us, and in fact demands that we think complexly across multiple levels, biology, psychology, psychosocial determinants of health. So that really excites me. I'm very interested in the thinking about both biology and psychology and mental health. Another factor is that, at least as I started, and thankfully it's getting a little bit better, but we have a long way to go, is that in general, women's conditions in health have been less studied. Up until very recently, when people were working on a cellular level, it was often cells from male human beings or animals. And we really are understanding that there are different biologies. And so, starting to look at maternal mental health issues, obviously, we're really understanding what biological sex can mean, as well as again the social conditions of people's lives. And it was just not studied very much to look at perinatal mental health. As I say, that's getting somewhat better, finally, but it was also very important and compelling to go into this understudied area.
Great. Yeah, that's so interesting. Thank you for sharing that. Um, it's lovely to hear as well, kind of your own mother having influence on then kind of leaning down this path. So, Dr. Monk, I understand a big part of your research has been not only assessing maternal mental health postpartum and after pregnancy, but also a lot during pregnancy and kind of looking further back. Can you tell us why this part is so important and what the data is currently showing us?
Yes. What we understand, and it's really taken a lot of research to, um, I think, get policymakers and clinicians to accept this reality, but we are there now, is that, for example, depression and anxiety are have comparable rates postpartum and during pregnancy. So, as there was beginning to be a concern about maternal mental health issues and really moving away from a um, really almost a caricature of the postpartum period that and that everything was just fine. We finally we got to an understanding of postpartum depression, and even more the caricature of pregnancy can only be a happy period. How could you feel anything except joy nonstop, which of course is unrealistic in general about life. Is we really now understand the rates are comparable, 10 to 15% on average of depression in the postpartum period, as well as in the pregnancy period. And I do want to highlight that depending on the circumstances of people's lives, those rates can be much higher if people are in very adverse conditions, experiencing poverty or war trauma, et cetera. So when we now understand that depression is as common in pregnancy as it is postpartum, that's a concern for the pregnant woman. But we then absolutely need to ask, does this have any impact on the child? And so I really came to my work with a developmental perspective. When I work with adult patients in psychotherapy, uh, in addition, of course, to using the wonderful tools we have now from cognitive behavioral therapy, et cetera, I need to understand from whence that person came. That influences the schemas, the outlook on life. It's the inroad to helping people lead happier lives, to recover from a depression. So a developmental perspective has always been with me, and I did developmental research always during graduate school with the more traditional approach of how is the mother's mental health postpartum, and how is that affecting the child as the child is growing. And we know that that's a compromised environment for the child. It's risk factors for the child. But the question became again, well, what about in pregnancy? And it was really serendipitous that I could pursue this developmental question in postdoctoral training. When it was just someone named David Barker, who was an epidemiologist in the UK, had started asking the question about poor nutrition and what does it mean for the child's future development in terms of risk for physical diseases. And we and many other labs started asking the question, well, what about mental health, which again is happening on a psychological level, but all that we experience psychologically is also happening on a biological level, our brain and our physiology. So if there's an altered mental health experience, a chronic depression, that's also going to be different biology for that developing fetus. It's an altered home. And does that affect brain behavior development? Because we now understand that particularly in the latter part of the second trimester and the third trimester, there's very much accelerated brain development happening in terms of where neurons are migrating to and some of the connections that are getting made. So my developmental perspective got pushed back in time. And this work matters because we understand that maternal mental health has two generation impact. The woman is being affected, but so is her future child, even before birth.
So fascinating. So it just, I mean, also it just emphasizes how important it is to have a focus on maternal mental health, not just for the woman, but it has so many further reaching implications for everyone in society. I mean, everyone has a mother, so
Yes.
to prioritize to prioritize maternal mental health is everything. Yeah.
Yes. Yes. You say it very well. Everybody has a mother.
So, with regards to the transgenerational trauma cycle, as you just mentioned, how do we see maternal stress and adverse childhood experiences being passed down to children? And in what ways have you seen or interventions that you've noticed have shown promise in breaking these cycles?
Right. Yeah, it's interesting. It's almost like the two generation is the potentially positive way to frame it, and the intergenerational trauma is the more negative. But both of them, we're talking about that again in this perinatal period. There's the mother and the future child. So really briefly, and highlighting some things that outcomes that we've identified in my lab, and wanting to note that there are many labs really across the world who are doing similar work. Um, I guess I want to highlight, first, I think what um, got a lot of people's awareness to the importance of this area from a two-gen perspective, that intergenerational perspective, was work on the Allspec data set that came out of the UK. It's in nearly 8,000 pregnant women who were followed, and now some of the most recent reports, their children are 14 years old. This is work of Vivek Glover and Tom O'Connor and Kieran O'Donnell really leading the way on this. And just a really important take-home message is that over different, excuse me, age periods for the children, 2 years old, 4 years old, when the mother had high anxiety or high depression during pregnancy, her children were at twice the risk for their own mental health condition. And typically it was an anxiety disorder or a depression. We've also done similar work and looking at more specific functioning. So seeing that the kids who were exposed in utero to mothers' untreated depression had a harder time inhibiting their actions. So inhibitory control was lower, and also paying attention. And obviously, those outcomes are components or symptoms of ADHD or anxiety. So very similar findings. But one of the challenging questions is, are we identifying primarily shared genes of risk for mental health conditions that are being passed on in the family, and we're just identifying them early at age 2 or age 4 or age 12? We meaning, again, the research community. And so we've worked, again, as other labs have too, to identify these effects in children before a lot of postnatal influence. So we can get closer, and I can talk more about the role of genes, so we can get closer to saying this really isn't about how the child is raised postnatally. We can see this early. Just to give you three quick examples, we see in fetuses whose mothers are more anxious or more depressed, that when their mothers undergo a stressor challenge in our lab in the third trimester, those fetuses are more reactive in their heart rate. And then the fetuses of women who don't react much to the stressor, and they're low anxious. And those fetuses go on at 4 months to have a very reactive temperament. And then we also see different connectivity in how the brain has been developing when we do imaging when they're newborns. So they have less connectivity, functional connectivity in a resting state between the frontal cortex, which can calm the brain and it's more of the control center, and the amygdala, which is very much involved in fear responses and emotions. There's less connectivity, suggesting a more reactive brain. And then finally, we can see changes in the genes, how they function in the placenta to make cortisol, the stress hormone, deactivated as it goes into the in utero compartment. So when there's greater stress, that protective gene gets turned off and more cortisol is going into the fetal compartment. And we know from other research that atypical levels of cortisol is associated with alterations in how the brain develops. So I'm just giving you little pieces to show this is really the evidence that this pregnancy mood disturbance is affecting the next generation. When we see trauma in pregnant women's childhoods, we see that that's a risk factor for them to have the baby born earlier. So it's this stressor of the childhood trauma is in the mother's biology as well as in her mind. And that means that she goes into pregnancy and the in utero environment is altered, and it seems to contribute to risk for earlier birth. So those are some of the many, many findings out there, but there are interventions, and I'm so glad you asked about that. There are three, I mean, first of all, mental health, and I hope we get to talk about that. Mental health interventions are very, very effective. But I think one of the most exciting areas is prevention. And there are three evidence-based programs specifically tailored to preventing postpartum depression, and they start in pregnancy. So if you start in pregnancy, you're helping with mood regulation already in pregnancy, and presumably, we haven't tested this yet, but presumably helping the fetus to be growing in a more typical environment. But then you're preventing that postpartum depression. So mothers and babies out of Chicago and the Rose program out of Brown are two of the evidence-based programs. And then we have something called PrEP, which is practical resources for effective postpartum parenting. So it's coaching, and it starts late in second or early in third trimester. My very close colleague, Elizabeth Werner, we developed this together, and she offers the trainings, in fact, internationally. Briefly, it is a brief intervention, 5 sessions. And it's focused on tools for the mother and her mood regulation, what we call psychoeducation. So, understanding and helping anticipate how much the baby may cry, what is postpartum depression, some reflection on how she wants to parent, how she was parented, which can also help with mood regulation, and then tools for helping the baby to be more regulated once the baby arrives. But we start these in pregnancy with the idea that as the baby is better regulated, the mother is doing better because they feed off each other in their moods. They really influence each other, mutually influencing. Uh, but also feeling like you have a toolbox for helping your baby sleep, be less fussy. That can boost your confidence. That can boost your sensitivity and how you're feeling about the baby. It's a very mutually influencing cycle. And we've shown that people who undergo PrEP in a randomized control trial compared to those who don't, and these are women at risk for postpartum depression based on high stress levels and distress in pregnancy. Um, they have lower levels of depression and anxiety postpartum, and some indication that early on they're actually sleeping better when in that early newborn period at 6 weeks.
Wow. Wow, that's amazing. I mean, it's so fascinating to hear how kind of how strongly linked biology is to maternal mental health, especially for the fetus. But it's, I think, really positive to know that there are really effective interventions of what I'm assuming you're saying is identifying women who are at risk and then
Yeah.
implementing preventative measures for these women in
Yeah.
particular. Yeah.
Exactly. And we can identify that is really
Mm,
not sort of not our problem. We
mm,
can listen to what women say and do different screenings and see those women who are experiencing a lot of distress, already some mild depression, and those
mm.
people we want to do prevention with them.
NMM have done kind of research on maternal mental health, and while it's focused in Europe, I'm sure it kind of represents a wider issue as well. And in the 2024 report of the State of Motherhood survey in Europe, we found quite worrying statistics of 50% of mothers suffering from maternal mental health and 67% reportedly feeling overloaded with work at home. So, from your research on preventable measures, what do you think should be prioritized in prenatal care to ensure better outcomes for mothers and subsequently their children?
Yeah, it's really rather devastating to hear about those statistics that you identify the data you identified and the trend, I should say, this phenomenon you're identifying and how high the rates of distress are.
Mm,
Um, I do think that one of the three evidence-based prevention programs that I mentioned, Mothers and Babies, the ROSE, and then our PrEP, um, ideally would be part of routine care. Um, and sometimes, at least in the US, what gets discussed is the challenge that people are concerned about screening for mental health conditions because they don't know that they have a place to refer people. So, and I gather we can hopefully talk about that more, that the issue of the workforce, mental health workforce, and how to get people access to care. But when we're identifying people at risk for postpartum depression and really making this a part of routine care, I think there's a tremendous opportunity, really, listening to patients. I mean, it can be from routine screening, but also listening to patients and saying, you sound very stressed. So catching them before it's a frank depression, and then building into the practices one of these, again, evidence-based prevention interventions would help a lot to lower the rates of distress. Um, I also think that there's, at least in the U.S., bringing in in a sense, additional team members, if you will. And this is happening in a rather patchwork way. And in many ways, the resources, it's not, people don't have equal access. But in the US, doulas, pregnancy and postpartum doulas, are viewed as experienced as offering a lot of support. And there's, um, you know, good emerging outcome data that they are helpful in terms of people feeling supported and diminishing stress and anxiety and depression and helping with birth outcomes. Um, so doulas and the visiting nurses program, that being more routine so that people have more contact postpartum. There's the very distressing line, the sad line of women feeling like the candy wrapper after they give birth, and that the focus becomes on the baby, and in fact, often their focus rather than on their well-being. And in fact, that can happen in pregnancy if people get viewed as it's only my health for the baby and not also how I'm doing. To speak very broadly, in the US, and I gather in other countries that are overall relatively well resourced, pediatrics has shifted to become a practice that's more oriented to the whole person and the whole family. And there are different programs like Healthy Steps and Healthy Starts and Reach Out and Read, where they're thinking about what is the psychosocial development, not only the height and weight growth of this baby, how is this family functioning, and what are resources we can bring in and do networking around what does this family need. And I am interested in this center that we've established, the Center for the Transition to Parenthood, and working cross-sector with doulas and nurses and OBs and policymakers. Can we have a vision, and we do have a blueprint of a vision now, of how to make the obstetrical, the perinatal care ecosystem somewhat more similar to how pediatrics has developed, so that there are not only available mental health care, which is essential, and again, I'm assuming we're going to talk about that more, but also what are some good apps to recommend your patients use that can help with the stress, the anxieties about becoming a parent? What about access to doula care? What about having a birth preferences discussion so people feel they have more agency and knowledge as they collaborate and go into the actual birth experience? And that can help with equity and care. Bringing in partners is very important. How to do that, how to support social networks. There are a lot of touch points, and our website describes the blueprint and then lists resources nationwide, different organizations that are providing these kinds of tools. And it's there, these resources are there for people to find locally where they live, but also to help support a networking of the overall perinatal care ecosystem. How can we all work together and learn from each other? These different services that are there, we need more of them, and they need to be better connected with the direct OB's care that people are getting, most often in the US with an obstetrician or a midwife. So I think that's a vision that could also really help address some of the despair that people are feeling.
Yeah, definitely. I mean, I guess building more of a community understanding is always going to benefit people. And from my understanding, it's not just about multidisciplinary care, but it's also about having that holistic approach and seeing the woman as a whole and seeing every aspect that she needs, not just the physical. Is
Yeah, that's so great, right? It's the WHO that says there's no health without mental health.
Yeah,
We
yeah.
really have to be with this whole person, for the pregnant person, for her child, and then how the family, getting them off to the right start if there is a partner, how they're doing, because of course how the partner is doing in his or her mental health is going to have a lot of effect on the pregnant person.
What would you say are some of the biggest challenges in implementing a multidisciplinary approach, and why do you think it's so important in ensuring effective care for women?
Mhm. So let me just start with the latter part, if I may. Yes, I work alongside obstetricians and their teams, so midwives and nurses and physician's assistants. Um, And I think that that is so important. We are an integrated mental health service within obstetrics. And I think that's so important because um, having us there allows the obstetricians to do their job, to do their expertise. So, and that then works for the patient. We definitely collaborate at times and communicate as it's needed. But the obstetricians have huge responsibility, obviously, for two or more lives. Um, as you know, the US and other parts of the world have serious challenges around maternal mortality and morbidity and um, health disparities and those outcomes in terms of which groups of women are most affected. So there is so much going on. And yes, as we were saying, mental and physical health are part of whole health and they do affect each other. But I was not trained to deliver a baby, and the obstetrician was not trained in mental health. And so we can do our work, I like to say, as an orchestra. We each have our parts. And so that's been actually a really easy part of implementation. It's sharing and getting used to each other's different cultures, but because I think for the most part, the specialty in obstetrics, those people with that focus appreciate our expertise, and we're taking work off of their plates. It has worked extremely well, and I'm just so privileged and really appreciate the ways that we work together, and we get great feedback from patients, very positive feedback. I think the challenge comes in terms of working across disciplines when it's less clear exactly, in a sense, what the deliverable will be. Meaning, we have this vision, as I was describing to you, that, um, uh, for example, obstetricians could refer their patients to apps that we think can be very helpful. My colleague, Dr. Warner, is on a particular app, the Pregnancy Plus app, which people get because they want to measure, they want to know, oh, my fetus is what size now. But she's actually talking about the transition to parenthood and what is it like to be becoming a parent, that psychological aspect. We want our OB colleagues to know about this. And they have very little time with patients based on sort of how the systems work. I'm assuming it's the same in other very developed, highly developed countries. It's hard for them to take in new information and do additional things, even if it's brief, in their workflow that's so tight when the deliverable, what is their patient going to get from this is not as clear. So I can see their patient for depression, but it just changing workflows is hard. So implementation is hard, and we're trying to shift the culture towards this whole person care. And we really just began. So I'm very optimistic we can get there, and they are, working across disciplines. We found people to be great colleagues. But I know for myself, and if we just think about our individual lives, shifting workflow, whether it's home and how the pattern you use to make coffee, or whatever the workflow is, when you're in a situation of life and death, because the OBs are very much in those situations often, it's hard to change the workflows. So I think that is a challenge. And part of that is our healthcare systems do not pay for implementation. There's not the sort of fat, if you will, the extra funding in the way reimbursements work, at least in the States, as our insurance systems are set up, to pay for. It's all very clocked in what I am paid for when I see a patient. There isn't the extra dollars for me to or for the OB to spend the time practicing a different workflow, seeing what works, what doesn't work. So people do it out of their commitment to changing cultures. We offer free virtual support groups called Rolling with Parenthood for pregnancy and postpartum. And the OBs and their teams are very much in favor. But getting that into the workflow, into the electronic record, so patients get an automatic announcement about it, this is huge just effort in workflow, and we're all doing it. out of commitment to how this could be great for people's well-being. But we're kind of wringing the time out of stone because there's not the extra time in the systems for implementation.
Yeah, I mean, I think same in the UK. It's so hard and it takes so long to make things common practice, and to have it implemented as a given in people's care.
Mhm.
Um, and it does take conscious effort. It takes people that want to make change, like you said.
Mhm.
Um, so yeah, I mean, while it's amazing, it is amazing utilizing everyone's expertise, and but I feel your pain on the time it takes to get these things in motion, definitely. Yeah.
But if I can add, and I should have said this earlier, um, I am a clinical psychologist hired in an obstetrics and gynecology department. And I think this is where, at least again in the States, medicine is talked about going. Really collaborations across discipline. And my identification is with my department. And I think that is a really good foundational piece. I'm not on loan from the psychiatry department. I'm not on loan from somewhere else. We absolutely need to collaborate with our community experts, our doulas, other groups. That is essential. But I think that I am um, right within the obstetrics and gynecology department from a different discipline is really does help the implementation piece and making change.
One of the barriers you've highlighted in your work is the lack of access to mental health care for pregnant and postpartum mothers. What steps do you feel can be taken to improve access to mental health services during pregnancy? And on top of that, how do you feel healthcare providers can better support those who might be at risk or even hesitant to seek care due to
Mm.
maybe stigma or lack of resources?
Mhm. So I'm just going to start with the latter again. Um, there are in the US and the UK and Australia actually is a great leader. There are national organizations around like Postpartum Support International in the US and similar organizations I know in these other countries that are national so that individuals or obstetricians or midwives can contact those organizations to get their patients mental health care if the locally they can't do it in their own practice or um, they're facing other challenges getting mental health care. And that again is a kind of resource that we have on our Center for the Transition to Parenthood website is what are some local groups that provide or national groups that have local connections that can provide mental health services. And I think in terms of the stigma, often people say that's a silver lining of the pandemic because so many people experienced depression or anxiety in the context of the pandemic and realizing it's such a personal or experiential, like, oh, I now I understand these are common experiences, right? 50% of adults in the US will have a mental health condition at one point in their lives. Very, very common, and it's usually anxiety or depression. The pandemic gave people lived experience, this major stressor and disruption or loss of, people I love. I got depressed. Now I have a better understanding. I think there's less stigma.
Mm.
And maybe it still is there in terms of particularly in the pregnancy postpartum period of I want this baby. I'm not supposed to feel this way. What's wrong with me? But there's so many factors, again, psychological, biological risk factors that can contribute, particularly actually traumatic childhood is certainly one of them.
Mm.
Um, that accepting these are common parts of the human condition and like a lot of health experiences we all have and help and prevention can really make a difference. Now, the problem really is accessing care. Um, and this is where I appreciate some similarities, but I don't have the firsthand knowledge, so I have to be very US centric if I can. Um, what we have in the US, particularly in the urban areas, is we don't have an access to mental health care problem. Um, if you can pay what's called out of pocket or privately. So let me shift that around. The often the problem accessing mental health care is framed as a workforce shortage. We don't have enough mental health providers. In the urban areas, Chicago, New York, LA, Washington, D.C., even more mid-sized places, the workforce shortage is those doing mental health care, expert in it, and taking insurance. And then finally, our model, which my chair, Mary Dalton, Dr. Mary Dalton, really had the vision for, of bringing a mental health team within obstetrics and gynecology. Part of the financial challenges that we're solving around the low reimbursement rate for mental health care is that the cost to have people get the money from insurance companies, that's an administrative cost, is being shared across a lot of different specialties. And those specialties, frankly, earn much higher reimbursement rates than I do. So it helps compensate for the low reimbursement rates that we are diversified in our specialties in terms of getting reimbursement from the insurance companies for all that we do. So really being direct hires, really being embedded in the obstetrics and gynecology is a version of a solution and a scalable solution to make mental health care more accessible for pregnant postpartum women.
I guess it does speak for kind of more of like the systemic and institutional value that's
Mm.
held on mental health services in comparison to other healthcare services. And I don't think that's just a US issue. I
Yeah,
think that spans globally.
yeah.
So, you know, so much needs to be done to, I guess, saying that the stigma is very much embedded
Mhm.
into healthcare attitudes. And while it's fantastic that patients might feel better and more accepting. And the conversation about mental health has kind of improved since COVID. There is still that underlying kind of channel of stigma that runs through and is trickling down in the system as well. Yeah.
Yeah.